In this video, we'll talk about AAA, or Abdominal Aortic Aneurysm. AAA carries the same risk factors as atherosclerosis. Smoking is the most important modifiable risk factor. It is more common in males, older than 65, with hyperlipidemia. Connective tissue disorders such as Marfan and Ehlers-Danlos syndromes carry the risk of aneurysm as well. A patient with a AAA may have an abdominal pulsatile mass dilating at, on average, 0.2 to 0.3 centimeters per year. They may have back and flank pain, limb ischemia, cyanosis of toes, or blue toe syndrome due to microemboli that form in the aneurysm. There may also be hydronephrosis from ureter compression, anorexia, DVT, and, in the case of inflammatory or mycotic aneurysms, constitutional symptoms. Mycotic aneurysms are most commonly due to staph or salmonella bacteria, making mycotic a bit of a misnomer. Screening consists of ultrasound in 65 to 75-year-old male smokers and should be considered in females as well. Suspected aneurysms should be definitively diagnosed with a CT scan, and CT angiography should be performed for treatment planning. Treatment involves the usual smoking cessation and lifestyle modifications, statins, and blood pressure control, as hypertension can precipitate dissection and rupture. Ultimately, surgery or endovascular repair called EVAR may be needed. In general, EVAR is for stable patients who have no calcifications or calcifications of less than 50% of the circumference of the aorta. Surgery is for emergencies when the aorta ruptures or is actively dissecting. Dissection is the intima tearing off of the media, which can lead to tearing, back pain, and eventually rupture. This usually actually occurs at the weakest point in the vessel wall, which is at the depth of the vasa vasorum, which is actually inside of the tunica media. Essentially, the intima and a small amount of media dissect from the rest of the media. Monitoring is indicated every 12 months for males with a 3.5 centimeter aneurysm and females with a 3 centimeter aneurysm. 4.5 centimeter male and 4 centimeter female aneurysms should be screened every 6 months. 5.5 centimeter aneurysms are those that enlarge by 0.5 centimeters in 6 months or 1 centimeter in 12 months should be repaired. If the patient acutely has tearing pain or dissection, they go to surgery emergently. In the interim time, you should control the patient's blood pressure to prevent further dissection and rupture. Complications include fistulization between the IVC and aorta, leading to CHF, or between the aorta and duodenum, which leads to GI hemorrhage. These complications take months to form. More immediate complications can include AKI from contrast, clamping of the abdominal aorta, or renal infarction due to release of emboli from the aneurysm. There may also be limb ischemia from blockage of an aortic branch due to emboli or stent thrombus, sexual dysfunction, autonomic nervous system damage, or inferior mesenteric artery ischemia due to improper graft placement. The patient needs surveillance duplex ultrasound and may develop stent graft complications unique to EVAR months to years later, such as migration of the graft, endoleak, or leakage around the graft, or infection. Thanks for watching. Please like, comment, share, subscribe, and hit the notification bell for more great videos. Remember, if you don't want to miss it, look below and click it. Check the description for more great study resources.